On behalf of the American Heart Association, I would like to welcome you to this session, Putting Evidence into Action, Real-World HFpEF-HFmrEF Treatment Model. This session explores innovative real-world treatment models that bring evidence-based therapies to life through multidisciplinary team-based care. Attendees will gain insights into how integrated approaches combining clinical expertise, behavioral health strategies, and coordinated care planning can drive measurable improvements in patient outcomes. Through case studies and practical frameworks, the webinar highlights how operationalizing these models enhances collaboration, efficiency, and long-term impact across diverse healthcare settings. Throughout this session, you will have the opportunity to submit text questions for our speakers using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of the presentation as time allows. To access live closed captions, please click on the closed caption button found on your screen. All sessions will be recorded and available in the coming weeks. It is my pleasure to welcome our speakers to this session, Dr. Cody Parsons, Dr. Chu Lee, Dr. Ryan Sandoval, and Dr. Abda Khandawal. Dr. Parsons is a board-certified critical care pharmacist who serves as the Director of Clinical Operations for the Cardiovascular Health Service line at Stanford Healthcare. Dr. Chu Lee is a board-certified ambulatory care pharmacist specializing in heart failure management and a certified diabetes care and education specialist. Currently, she works as a clinical pharmacist in the cardiometabolic clinic at Stanford Healthcare South Bay, managing patients with heart failure and dyslipidemia. Dr. Sandoval is a board-certified cardiologist and serves as a clinical assistant professor in the Division of Cardiovascular Medicine at Stanford University School of Medicine. Dr. Khandawal is a clinical associate professor in cardiovascular medicine. She is the ambulatory clinic chief for cardiovascular medicine and quality chief for Division of Cardiology at Stanford University School of Medicine. As a reminder, full speaker bios can be found in the event lobby. Dr. Parsons and team, the floor is yours.
Thank you so much, Nancy, for that introduction. And thank you, everyone, for joining us to talk about our journey in creating a pharmacist-managed cardiometabolic clinic, which one segment is addressing those patients with HFpEF and HFmrEF. We have nothing to disclose. And here is the core team behind this clinic, some that you've already heard the names of as they will be presenting. And the one that's called out here that is not presenting is Carmen Liu, our Director of Ambulatory Pharmacy for Stanford Healthcare. So a little bit about the organization. Stanford's an academic teaching hospital of the Stanford University School of Medicine. It was established in Palo Alto around 1959, and its main campus is located 40 miles south of San Francisco and 20 miles north of San Jose. The community that we serve represents 21 counties within 5 separate regions. Stanford Healthcare does have a sister facility, Stanford Healthcare Tri-Valley, and Stanford Medicine Partners. And its total is the adult healthcare delivery system of Stanford Medicine. Some quick facts. We are a quaternary center. We have a hospital, 500 Pasteur, which opened for operations in 2019 with around 824,000 square feet of space. We are the only level 1 trauma center between San Francisco and San Jose. When looking at outpatient visits, we are just shy of 1.5 million visits annually. The emergency department volumes are just shy of 85,000 annually. And if we're looking at video visits, we're just above 500,000. In terms of beds, 643 licensed beds within the facility. I'm going to turn it over to Ryan to tell you a little bit about the service line as a whole.
So a little more background on cardiovascular care at Stanford and through Stanford. So Stanford has a kind of a legacy of exceptional caliber of cardiovascular care, and it's really through this kind of multidisciplinary approach and collaboration, interdisciplinary amongst various divisions and departments. And in addition to the clinical care, I think what also makes Stanford stand out is its kind of cutting edge research that it's heavily involved in. The This slide here kind of illustrates some of those departments and how they make up a whole in terms of our cardiovascular care and allow us to provide, well-rounded care that's individualized to the patient need. And a couple specific highlights, involved here. We have listed not only the pediatric side of things with exceptional care for our pediatric patients, but through our Department of Cardiothoracic Surgery and in collaboration with our advanced heart failure cardiologists, we're one of the largest heart transplantation and LVAD centers in the country and by extension the world. In addition, we have the interventional cardiology side and our exceptional heart and valve team, which works on complex cardiac cases, especially with the help of our cardiac anesthesiologists, to really provide novel transcatheter approaches to structural diseases, both valvular and non-valvular interventions. So that's another very strong aspect of the care that we provide. Additionally, we have our research, which is heavily supported by our Cardiovascular Institute, which helps support our physician scientist faculty that help us stay on the leading edge of research. And then Cody also mentioned the Tri-Valley and some of those extensive or kind of outreach centers to kind of broaden our reach outside of our main campus. So our Stanford Cardiovascular Network allows us to reach out to patients in the East Bay and the South Bay as well. So kind of a strong team effort in our care. Cody, you can go to the next one. And then this is a breakdown of all of our ambulatory programs within our cardiology department. And under the major kind of headings would be the non-invasive cardiology, our heart failure and cardiomyopathy clinic, and then our interventional cardiology. I would also put in there the cardiac arrhythmia services as potentially our EP services as a separate major category there. But you can see illustrated here just how much kind of specialty care we can provide patients, and we can definitely individualize care. And I'll make a quick plug to, the work that I've done with the help of some of my colleagues in creating our HFpEF and dyspnea clinic, which is kind of involved in this group here and what we're talking about today, which is trying to get these patients kind of exceptional care that they may not otherwise get. And that's been largely supported and helped by the cardiometabolic clinic, which we'll talk more about today. On both the HFpEF side, any heart failure with reduced ejection fraction as well, in addition to our other cardiometabolic disease that play a large role in both of these entities. And you can proceed, yeah.
Thank you so much, Dr. Sandoval. So the beginnings, what really prompted us to start looking about a solution for these HFpEF and HFmrEF patients as it relates to both guideline-directed therapies and diuretic management? Well, you can see here the population from 2022 through 2025 of essentially those primary patients, of the breakdown between those with EFs greater than 40 and those less than 40. As you can see here, you can see that in the gray line, you see those EFs greater than 40. The HFpEF, HFmrEF population was making up well above 50% of those primary heart failure admissions, upwards to mid 60s to upper 60s. So it's a significant population that we decided we needed to extend more resources to. Another lens was around the Vizient Quality Consortium in their ambulatory quality measure PQI-08 around heart failure admissions. For those unaware, the numerator is heart failure admissions seen by an ambulatory billing clinician prior to the admission, and this was limited to patients who had at least 2 visits to primary care or 2 visits to cardiology with a diagnosis of heart failure prior to a primary heart failure admission. And then the denominator was heart failure admission seen by an ambulatory practice billing clinician prior to the admission. So when we talk about the preeminence side of things and looking at that benchmarking organization, this was another consideration that played in. And then I'll turn it over to Ryan for the vision.
Yeah, so moving on to talk about the vision behind the cardiometabolic clinic. And a little bit about what it is. It's a pharmacist-run clinic, and really it's focused on medication optimization and titration. As you can see, it's leveraging protocolized care pathways. So a lot of it's driven by the protocols, which I think Cody and Chu will tell you a little bit more about later in the presentation. But ultimately, it's looking at least as of now, we have certain disease states which we can refer to for this medication optimization, and it's been immensely helpful. So those include lipid management, GLP-1 initiation, and then heart failure medication management across the board of EF. So can be HFrEF through HFpEF and anywhere in between. And really the goal is frequent visits to get the optimization up to speed as quickly as possible. And that definitely improves patient satisfaction to be able to work with somebody closely to not only improve the medication regimen that they're on, but also deal with potential side effects and then adjusting doses as needed to accommodate that. So it's been helpful both on the patient satisfaction and from the physician standpoint as well. And I think one of the major benefits to it is it does relieve access burden from our physicians and APPs, because ultimately it can be very hard for the physicians and the APPs to accommodate as frequent visits as we would like to get these patients on the medications they need to be on. So it's been immensely helpful. And I would say, just from my perspective, anecdotally speaking, especially with the creation of our HFpEF clinic and kind of in its infancy, the cardiometabolic clinic has been very helpful to get people on the medications they should be on, that we know affect outcomes. And obviously it starts with a good protocol, but the additional benefit here at Stanford, at least, I think, and for anybody that's looking to replicate this, would be getting a good pharmacy team behind you. And that's where I would send my immense gratitude towards Chu and Cody for helping set this up, because it's been a major help. You can.
Thank you, Ryan. And I do want to add 2 other points around the need. When we looked at about a 4-month segment of our heart failure readmissions, they relied on 2 services primarily. Either CV medicine services, or the second largest was hospital medicine services. And when we took those readmissions and broke them down, what we found was the leading reason for readmission in both groups was lacking or lack of treatment optimization. So that was identified as a strong opportunity. Patients were going out with the suboptimally in terms of medication prescribing, and for the period after, there was no intensive attempt to ramp up those 4 pillars of therapy, if it's HFrEF or some of those other medications if we're talking about HFpEF and HFmrEF. Specifically, when you look at the individuals that had a EF greater than 40, and specifically around SGLT2 inhibitors prescribed at discharge, we did see, when we looked at both male and female, did they go home on the medication? Males, around 58%. Females were only 43%. Now, when we look at that number, and it added in, was there a contraindication noted? Males were up to 75%, and females were at 68%. So looking at it, we did not like that we saw also a discrepancy between male and female, and overall, there was obvious need for room to improve within these populations. Next, we're going to go on to visit logistics, and I'm going to turn it over to Chu.
Thank you, Cody. So for our cardiometabolic clinic visits, we design to be 30 minutes visits, either in person or video. And we find that the video option is really beneficial, especially since we're seeing patients every 2 weeks. It can be a little bit of a burden for patients, especially the elderly population or those with limited transportation or those who live far away. So having the video visits is really helpful to enhance adherence to the program. These are independent visits with the pharmacist. We put the medication order under the referring physician, and we can send the order directly to the pharmacy. It doesn't need a co-signature for it to be filled. However, in Epic, the referring MD still get a notification to co-sign the order, and this is helpful so that they know that a medication was ordered under their name. We also order labs under the referring MD. The pharmacist get the lab results back we get the results back in our basket, and we assess it and reach out to patient to adjust medications as needed. So basically we are in charge of the labs, but the physicians also sees the lab result as well. We route the note to the referring MD to update on any changes. And then a co-signature is required from the on-site supervising MD. This is for Stanford Healthcare billing purpose, which Cody will go over in a little bit. We are in the process of getting pharmacists credentialed. So when this process is finished, the pharmacist will be able to order medications and labs under our own credentials. Next slide, please. So for the visit structure, this is very similar to any office visit. We have the MA help to obtain vital signs and doing MedRec. If it's a video visit, the MA will obtain the home blood pressure and weigh and record those for us and do the medication reconciliation as well. They also help with any technical difficulty, to make sure the patient can log in to the video visit okay. And then when we come in, the pharmacist will review the medications and screen for drug-drug interactions. We do patient and caregiver interview to assess their symptoms. And we would do basic physical exam, including listening to the lungs, check for JVD, edema, etc. if it's an in-person visit. And then we will come up with a medication management plan based on the protocol. We order labs as appropriate, and we provide the patient education on medications, on the symptoms, whatever is necessary. There is, one important thing that we do is we want to resolve any medication accessibility issues, including submitting for prior authorization, assisting with financial assistance application if a patient cannot afford a certain drug, if they meet the criteria for manufacturer financial assistance program, we can help with that. We also give them tips on applying for or obtaining good RX coupon, copay cards, etc. And then for the wrap up, we want to make sure that we give patient very specific instruction. We type up the instruction and put it on the ABS. If it's an in-person visit, every patient goes home with an ABS printout. If it's a video visit, we send the secure message on their My Health app with very specific plan on what to do with the medications and the next follow-up. Next slide, please. Okay, it's you.
Okay, so I'm going to talk about the financial considerations from an operational standpoint. When we, across the US, a lot of pharmacists tend to justify their work through cost savings and not necessarily through a billing pathway. And, this tends to be of interest, especially for academic medical centers where, site of service is important for how we can bill outside of, our physicians and our advanced practice providers. So we leveraged incident to billing for this clinic where we bill provider rates using evaluation and management CPT codes. Looking at the Medicare requirements and considerations, it has to be a non-institutional setting. So that's why, this is an important important concept for an academic medical center, as a lot of clinics tend to be institutional settings. The supervising provider must be present in the office suite and immediately available to provide assistance and direction. Any provider of the practice group may be present in the office. It doesn't have to be who provided that referral and who signed that collaborative practice agreement. The referring provider must have initiated the treatment plan as well. So when we talk about that place of service, it has to be in a place of service 11 and not a place of service 19 or 22, which you often see with academic centers or larger health systems. It can also be at the patient's home, which is a place of service 12. So that said, we strategically placed Chu in the services in a place of service 11. Unfortunately, her services will never be able to be offered at main campus, where some of our core clinics reside. However, it's okay. It's easier, for individuals to go to some of these satellite clinics that's closer to home, and they don't have to deal with, the traffic and parking that's usually associated with a large academic center. So when we talk about those physician fee schedules, you can see here the levels, and we do time-based billing. So, for example, if Chu does a 30-minute visit and spent 15 minutes prepping for it, it could easily fall into a level 4 or level 5, and you can see the estimated reimbursement on the right for that visit. If anyone has questions about this, the American Society of Health System Pharmacy has a great resource on it, as does American Medical Association. Just dig around and you can find some resources discussing this. Some considerations. So our personal, Stanford Healthcare's CMS claims processor required that the in-clinic physician co-sign the note. To note, this is not a CMS requirement. So that could be very dependent on who your processor is. So I would, in these situations, please partner with your billing, compliance, and legal teams to figure out the correct way to get this through. With the CMS guidance, it said it has to be a physician of the same practice. I discussed initially in the larger Stanford Healthcare Network, we have the faculty practice, and then we have the Stanford Medicine Partners, which is our community-based practice. Unfortunately, we currently cannot offer services to patients of that community practice, as the physician in clinic that Chu bills to is not part of that faculty practice, but rather that community practice. We may toy around in future years of creating the correct legal agreements to allow that exchange to occur. And then I'll turn it over to discuss some of the guiding documents for this clinic.
Thank you, Cody. So to get our clinic started, we established a collaborative practice agreement, which required approval from the Stanford Healthcare Office of General Counsel and P&T Committee. So the CPA, the platforms that we use to send this out is via Adobe Sign, and the physicians will get the electronic signature invitation via emails. This allows for record keeping and tracking of signature copies. Note that physicians and pharmacists may withdraw from the CPA at any time. And the respective parties on the agreement will be notified. This also allows for addendum if services are added and notifications to be sent out to all signatories on the CPA. And we use Smartsheet to keep a list of all the physicians who have signed the CPA, so that when we get a referral, we can go back to double check to make sure that the names are on the list so that we can legally take that patient. Next slide, please. Oh, next slide, please, Cody. Thank you. So we started off when we first started the clinic, initially for the CPA, we started with the HFrEF population and lipid management protocol. So those were the first two protocols that we had on the CPA. And when the HFpEF and HFmrEF protocol and the GLP-1A protocol got approved, we addended that to the CPA and notified the physicians for the second round. Next slide, please. Oh, next slide, please, Cody. So at our institution, we do have a lot of advanced practice providers. Please note that APPs cannot enter into a CPA with a PharmD this is per Stanford Healthcare interpretation of regulations. So at our institution, to refer, APPs can refer patients, but they must put the referral under the name of the supervising physician, and it does require a co-signature from the supervising physician. And the supervising physician must already have an executive CPA with our program. So we suggest that you partner up with your billing, compliance, and legal teams for this process. Next slide, please. Okay, next I'm going to talk about our protocol. So this is for the HFpEF and HFmrEF protocol. The inclusion criteria, patients who are established with Stanford School of Medicine physician practice can be referred. And for heart failure with preserved ejection fraction, of course, that means a VAF over 50%. And also patients with mildly reduced ejection fraction, defined as patients with LVEF between 41 to 49%. We exclude patients who have New York Heart Association Class 4 symptoms, people with history of advanced heart failure therapies such as LVAD, cardiac transplantation, palliative care, palliative inotropes, or plan for advanced heart failure therapies. We also exclude patients with history of infiltrative cardiomyopathy, such as sarcoidosis, cardiac amyloidosis, and moderate to severe valvular disease. We also exclude patients with significant pulmonary disease, pregnant or lactating women, and those who were discharged from a hospital to a long-term care facility. Next slide, please. So what are the pharmacist's responsibilities per protocol? We base our protocol on the 2022 AHA-ACC HFSA guidelines for management of heart failure. So for HFmrEF, it's the 4 pillars, the beta blockers, ARNI, MRA, SGLT2. And as we mentioned earlier, we also, the pharmacist can also adjust diuretics and other hypertensive medications as appropriate. For HFpEF, besides the GDMT medications, diuretics, and antihypertensive meds, we added a GLP-1 agonist for patients with BMI over 30 and HFpEF as well. So the pharmacist is responsible for monitoring, of course, the heart failure symptoms, any medication side effects, weight, blood pressure, vital signs, labs, all the appropriate labs, and diagnostic tests, such related diagnostic tests such as echo, the cardiac monitor, Holter, etc. Patients are counseled on lifestyle changes, low sodium diet, exercises. We can refer patients to the dietitian if needed. We also provide them a lot of information on food program for low sodium diet. We make sure patients understand heart failure symptoms, when to reach out for help. We discuss extensively about medication adherence, medication side effects, how to mitigate the side effects. And then, as I mentioned earlier, we do MedRec, big part of medication review for drug-drug interactions, drug supplement interactions, drug disease state interactions, etc. Next slide, please. Okay, so the build out for the referrals, it was when we first started, this was what it looked like when we first built the referral. So we had the lipid management and HFrEF. And for take 2, next slide. Thank you. So we added the after the heart failure HFpEF and HFmrEF protocol was added, we included lumping everything together under heart failure management, and we added the GLP-1 button as well. So these can be multi-selected, so physician can refer patients for all of these if appropriate. And so next slide, please. So this, I think, has
I want
the
to chime in on something there too.
yeah.
So, kind of like you mentioned, the important thing is these can be multi-selected. So if your patient needs multiple, disease state management, it can be included. For that initial referral, we actually tied it in to our referral to cardiology within Epic. However, we ended up pulling it out, which is why you see a referral take 1 versus referral take 2. Outside of progressively adding additional services, we went in and pulled it out, made its own referral, so we are able to actually capture physician co-signature for APPs. Given we had that standalone, the system is able to recognize if it's not a physician, rather a PA or an NP, and then force them to notate their supervising physician, and their supervising physician must provide co-signature. Now, to reduce confusion on the referral to cardiology, which you see here, we went ahead and added on in the dropdown cardiometabolic pharmacy services, which will reroute them over to that new referral order to make sure that, in case someone does get lost or goes back to the old referral to cardiology, it'll still get them to the correct place.
Thank you,
And turn it back
Cody.
to you.
Thank you. Okay, so we just want to share our note template, which is we adopted this from the heart failure, the notes that our heart failure providers use. So just typical SOAP note that is specific for heart failure management. I just want to call out a couple of things. We added a phrase that indicate that we discuss with patient that the clinic is operated under the collaborative practice agreement between the pharmacist and referring physician. And the patient was informed that the pharmacist may manage medications related to their condition in collaboration with the physician. And patient was also made aware of their rights to opt out this arrangement at any time. And then they give the verbal consent to proceed with the care under the CPA. And then at the bottom of the note, we also have a phrase that we say we saw this patient under the plan of care established by the referring MD. And then we also list the name of the on-site supervising MD who co-signs the note and the time that we spend prepping the chart and talking to the patient, basically the time that we bill for the visit. Next slide, please. Okay, so for PharmD clinic support, we are lucky to have the support of the scheduling staff who help review the referrals. They make sure that the referring providers had assigned CPA on file, as I mentioned earlier in the Smart Sheet. And then they help book initial PharmD appointments, either in person or telehealth visits. We have our medical assistant or clinic flow coordinators helping with the rooming. They also assist with prior authorization initiation, and I can tell you this is vital when it comes to GLP-1. I already saw there's a lot of questions on that in the chat, which we'll go over in a little bit. The medical assistant also help with booking follow-up visits and other clerical tasks such as faxing, obtaining medical records, etc. Next slide, please. I think this is yours.
Where we are today, so the populations that we currently serve, cardiovascular medicine, all specialties and subspecialties have the ability to refer to the clinic. A couple months ago, we rolled out to hospital medicine inpatient service. So, if they have an established relationship with the patient and they go to discharge them, at discharge, they are able to refer for medication titration. Once we get those patients, if they do not have a cardiology provider, we will then initiate a referral to cardiology while also titrating these medications and adding, subtracting therapies as necessary. Primary care, we are looking at slowly expanding our footprint within primary care. I think we're going to start off with about 2 or 3 primary care clinics and go from there. Again, there will be an evaluation on the pharmacist's part. Hospital medicine will be all comers get a referral to cardiology. When we talk about primary care, it will really determine on where the patient is at within their disease trajectory. However, we will be leveraging that referral to cardiology as well for those who do not have established cardiologists. Then we'll discuss some lessons learned. Drumming up referrals. No, went a little too far. This was a fairly new sort of idea within the cardiovascular health destination service line. And when I say this, I mean, a pharmacist managed clinic and being able to bill for those services. That said, the uptake was a little slow. What we did was we ended up doing kind of a roadshow where we went to various subspecialty uh, faculty meetings to present, a short slide deck and to give them 1-point lessons to distribute. Here you can see an example of our 1-point lesson that provides an overview of what services are offered, what the inclusion/exclusion criteria is for those services, and how to order it. We additionally threw in the caveat about, the APP workflow, where it will prompt them to enter their supervising MD and require that supervising MD co-signature. In terms of any other lessons learned, Ryan, do you have anything on your end?
Sorry about that. Yeah, I mean, I think in the time that we've kind of had access to this, I think I was a little initially kind of taking things on myself to manage some of these things, and there was a little hesitancy to offload that responsibility. But I think now, that I know what the service provides and how I think collaborative it is in terms of Chu being communicative with us to kind of co-manage the patient together. I think it's just been just a wonderful thing to have access to. So I would leave with that from my end, at least.
Cody, I just want to add one more thing on the lessons learned. I think it's been really helpful too for us to collaborate actually with the nurse coordinators who work behind the scenes supporting the physicians, but because they're the one managing the physicians in basket, communicating with the patients, helping to send referrals and all that. So it's been great collaborating with them so they are aware of our services, and oftentimes they're the one reminding the physicians to refer patients to our clinic. So yes, I think the collaboration has been wonderful.
Thank you for that, Chu. And also, as we're learning, in the more recent months, we've added on the ability to manage GLP-1s for those who have a cardiac indication. We have learned very quickly that we may have to limit the number of spots for those or slots for those daily to make sure the clinic does not get flooded, and preventing us from getting those frequent visits in with those heart failure patients. Okay. For future ideas, I discussed partnering with primary care, linking into some of the work they're already doing in terms of identifying HFpEF patients who are not on those SGLT2 inhibitors, review them for eligibility, and then doing outreach to both the provider and the patient. Also identifying frequent flyers, or as we call MVPs, multi-visit patients, and ensuring that they get enrolled in the cardiometabolic clinic. Something we're looking at in the future is, Stanford is not a low-cost organization situated where we are. That said, there are times where insurers will not pay for a patient to come get ambulatory services. So we're looking to see what we can do to extend at least some of these services to those MVP patients who may not have insurance coverage in the ambulatory environment. Here are our references. And then I'll turn it over for questions.
Thank you to the Stanford Healthcare team for sharing your expertise on this important topic and for a great presentation. We do have a few questions for our speakers. Dr. Parsons, I see that you answered several questions in the chat. We still have a few more. One question from Dr. Alloway, who was a speaker in a previous session, is how much success have you seen with GLP-1A in HFpEF?
I think I can take that question. Not with HFpEF, but a lot of our patients who got referred also have other conditions that we could use the, GLP-1A for when we submit for prior authorization. So usually when I get those referrals, I would screen, for example, if the patient has moderate to severe sleep apnea, we can use that as the indication when we submit for PA. I mean, they have HFpEF, but we know that it has not been FDA approved yet, the GLP-1. So if we submit it as with indication for heart failure, most likely it will not get approved. So basically, we just find from the patient, just very carefully review patients' medical records to see what we can use. And if they have diabetes, that's easy. But if they have other conditions, sleep apnea, usually we have a pretty good success with it. And of course, if they have history of MI, stroke, or PVD, those can, we can get approval pretty easily too. But yeah, it's tough. It's not easy to get them approved.
Dr. Lee, we have another question for you. Have you encountered challenges with GLP-1RA coverage in this patient population, and what strategies have you used to address them?
Yeah, so like I said, it's very, very tough. And it also depends on the kind of insurance patient has. I think for commercial plans, it might be a little bit easier. Sometimes I'm pleasantly surprised that we don't have to jump through 10,000 hoops to get it approved. But, most of the time, again, you have to look for, I think the key is to look for the FDA approved indications that the patient has and use that when you submit for prior authorization for these medications. Oh, sorry, Nancy, I think you're on mute.
I was on mute. Thank you. Thank you again to the Stanford Healthcare team for the wonderful presentation, and thank you to our audience for your participation. We will be launching a poll to evaluate the effectiveness of this session, and we appreciate you taking the time to share your feedback. Coming up next at 12:45 Central, we have our final session of the day, which is Barriers to Better Care, Tackling Health-Related Social Needs in HFpEF and HFmrEF Management. To access, please exit this session and return to the lobby using the menu at the top of your screen. From the lobby, click on the Sessions tab first, then click on the individual session to join. We have also posted a link to join directly in the chat. Thank you so much for attending today's session, and we will see you shortly.